So Dr. Florescue, thank you so much for your time and your dedication to these families. So tell us a little bit about your first experience with the Stillbirth Summit and what you expected going in and how it met those expectations or didn't.
Yeah. So I actually found Star Legacy for the first time when I went to the annual face-to-face balloon launch that is in Rochester. And I semi heard of it, so I started just Googling it. I actually found the summit, and ironically, I think within an hour of me finding it, Jen and Christina asked me, do I want to go to it? So it was really kind of an interesting, ironic twist. I've always been very dedicated to the loss community. I've always really enjoyed grief counseling. It's always been part of my life as an OBGYN. So I very much wanted to go. And then I think it was the second day that Dr. Caldwell spoke, which kind of really shifted entirely my focus, really from the conference at that point. I think there's a myth out there. I think there's a myth that we can't prevent stillbirth, and I think I believed in that myth. I think we do prenatal care for nothing else other than healthy mom, healthy baby. But I don't think we think that when the terrible thing like stillbirth happens, that we think we did so great with prenatal care that was going to happen anyway, and that it wasn't a preventable outcome because prenatal care is so good that it happened because these things are just inevitably going to happen. Even though I have many stories with a woman who didn't know to call us for 3 days because her baby wasn't moving, or it seems a common value. I went to my baby shower, I was so busy, and then I didn't think about the fact the baby didn't move for 2 days after that. So, and I should have known that was a preventable moment, but I don't think I made that connection. And then hearing Dr. Caldwell speak, especially since she was pregnant at the time, that she had this terrible weekend where she lost 3 babies in 1 weekend, and I had an incredibly high-risk pregnancy, and so I always had to face that down. And I always feared stillbirth, and I was somehow granted 3 beautiful, healthy babies despite a triplet pregnancy. And I think that really resonated with me, the why them and not me, why did I get to be so lucky, and I kind of wanted to bring home what she did. So I wrote Alex Heasel, and he sent me the protocol for the UK, and then I kind of ran with it from there.
So can you describe a little bit about what that protocol looks like?
Yes, so I've gotten really good at talking about it too. So the protocol kind of comes in 4 easy steps. One of them is reducing smoking, and they have a whole thing about carbon monoxide monitoring, which we haven't implemented in my practice yet. We have a pretty low smoking rate, and so we've really been doing just really encouraging the women to quit smoking, actually telling them that smoking has a risk of stillbirth, because I think moms need to know that, not that it's their fault that they're addicted, but they need to know the risks, and I think we kind of can do better with that. The second part is making sure we're not missing any growth-restricted babies. So, and what we've been doing, at least in my practice, is I've been doing a chart review, which actually doesn't take too long. I sit down on a Saturday or Sunday with a cup of coffee, and I go through all of our 32-week patients, because they all come in for a talk at our office. And I just review their chart quickly, write a little note, no obvious risk factors for fetal growth restriction, or if I find one, I tell the nurse to get that scheduled, and we have caught a bunch of growth-restricted babies already with this, kind of just reviewing the chart to make sure we're not missing anything. The big things that we haven't caught by routine prenatal care is really the big fundal height, the women due to morbid obesity or a large fibroid, or the women who had a marginal cord insertion that just didn't get picked up on, when somebody reviewed that result. Or very rarely the 15th percentile baby at the anatomic scan, which, hey, why not look again kind of thing. So kind of catching those women. The third step is really good education for our moms. And a lot of that is just saying the word stillbirth. And for the women who are really anxious, when I'm talking about stillbirth, I kind of say, if you let us know your baby's movements aren't right, you can save your baby's life. And kind of, for the women who I know that's not going to work for, but the vast majority of women handle the stillbirth word very well. One of the things I think was very profound that you guys put out was one of those kind of little messages about how we educate all of our moms about listeria, and that they should eat, no unpasteurized milks and cheese, but yet we lose 26 babies to that, which is of course too many, but every pregnant woman knows that. Every woman who has a child knows to lock up poisons, potential, things like that. Every mom knows to watch their kid like a hawk by the pool and make sure they don't drown in the tub. We talk about things that keep our kids from dying. Why can't we educate moms in utero about about things that may cause their kids to die in utero. So we're really doing very blunt education where call us if your baby's not moving, you're never bothering us, which is a really key feature. Some women worry about being the boy who cried wolf, and really reassuring them that's not how we treat our patients in our practice, and really just enabling them and empowering them to say something's not right. And the other thing that I've also been using, and every time I talk about this, is kick counts really haven't been shown to be as effective as we wish they were. So I tell them kick counts are more for when they're running around, kind of getting the nursery ready, or they're doing something with their older child and they haven't checked in on the baby recently. And that they can use it to check in on the baby, but if they're worried, the phone is all that they should be doing. Not juice, not crackers. We also are dispelling the myths. Babies don't slow down at the end, all those kind of things, making sure they really truly understand. The fourth and final step, which I think is the most important from the physician, provider, nurse standpoint, is the what do we do when the baby is not moving? So we directly took from the UK protocol a checklist that we use when a mother says that she's worried about baby's movement. We actually also are using it for women who have concerning increase in fetal movement, since we know that's also a potential risk factor. And basically we're saying, we kind of have a checklist. It says that the mother said she is concerned about this. The next step is is the mother have a risk factor for a stillborn baby? If she does, based on the protocol, within 24 hours, she's supposed to get an ultrasound, even if the non-stress test is reactive. So if it's not reactive, then we have a whole protocol system that we use. But for a reactive NST, even if it looks great, within 24 hours, the mom has to get an ultrasound. And then we do Dopplers if their baby is small or if there's low fluid. The next really important part about it is the are you reassured step. And one of the things I'm educating nurses and doctors and people about is we don't want to do you're okay with this, are you? We want to let the patient tell us how they're feeling about it. And I will tell you, 95% of our patients say, thank you for putting me on the monitor. I feel so much better about this. Thank you for empowering me and educating me. And they move on with their day. And it's that 5% that say, I get it, you're worried, and I'm worried, and I get that you're telling me this baby looks great, but I'm really not okay with this. And those are the women where we have to think of what is the right next step for them. We're kind of held to the 39-week rule, so for our women who have been less than 39 weeks, it may be phone calls just to check on you, it may be more frequent NSTs, it may be even a high-risk OB consult. So we did have one lady who really just couldn't stand it anymore, and high-risk OB signed off on a 38-week induction for her. But it's, really just kind of following them closely and making sure that they're feeling okay. But for the woman with recurrent decreased fetal movement who is worried after 39 weeks, induction is the protocol that we've established.
And how has this been received so far, both by yourself, your colleagues, and your patients?
So our colleagues have been amazing about it. My colleagues have just ran with it. I asked one of our nurses, because I've been going around all over Rochester trying to spread this, how do you feel about this? And she said they're 100% behind it. I think the nurses really feel good about it. I think it gives them a framework to talk about it. It gives a standardization to something that I don't think has been standardized at all. How do we talk to our moms about fetal movement? Mm-hmm. And I think it's just been really wonderful. I think our patients also love it. When you say to a patient, I went to a conference and found out what the rest of the developed world is doing, and I decide we're doing it women's group first, they love that. They love that we care about the safety of their babies. They're not freaking out about it. They're not shying away from it. I spend a lot of time saying to them, people, that bringing this in doesn't make it more likely to have a stillbirth, it makes it less likely. And that this is not contagious by saying the word and by instituting protocols. It's actually maybe reducing the risk, we hope.
Good. And have you been implementing the protocol?
Yes, so I think we have one more lady, I think, who's being induced at 39 weeks, so she's probably right around now. So I think it's somewhere around 9 or 10 people who we've really implemented. There's some people where we have a lady who's getting induced right now who is, gestational hypertension and, decreased fetal movement. So sometimes they're kind of having a couple things going on, but truly inducing for that reason, they're probably around the 8 mark. The most profound story I have is, really just the patients who are worried and everything's testing fine, and we found some really small babies by digging deeper. We found low fluid by digging deeper, and there's something there. And I really I think it was Dr. Kleinman at the conference who talked about the tank of gas. And it's been something that I've said so many times to patients that when we're driving our car's going 55 miles per hour and it's saying we have 40, miles left in the tank and the light comes on. The car's still running 55 miles per hour. And we don't know what it looks like before maybe it just runs out and the baby looks fine on the NST and all these things, the BPP may be still 8 out of 8. We don't know. And so we really have to say that these babies are not moving. There's a, low gaslight warning going, and we just have to take it seriously, so.
Absolutely. Good. Talk to me about when you are describing this protocol to your patients, and even if you're not describing the steps of the protocol exactly, but when you're mentioning the word stillbirth, there's a big fear that this will really make a lot of moms anxious or cause a big increase in office visits, and talk to me about your experience with that.
I don't think we've seen a ton of it. So I asked my billing manager actually to put together the NSTs, and we haven't seen this huge spike since we started introducing this protocol, because it really and truly, moms are educated about many things. You tell moms, call us if you have a headache because it may be a sign of preeclampsia. You don't all of a sudden get 400 people calling you saying, I have a headache, I might have preeclampsia. So it really is something that moms aren't, going crazy about. And my nurses, as I said, I kind of said to them, we're 2 or 3 months in, how do you feel about this? They're not like, oh my God, we're so overwhelmed with phone calls. I think they feel empowered to know what to do. They know the mother who was concerned yesterday, but, and calls and says, oh, by the way, my baby wasn't moving great yesterday, but my baby's perfect today. Probably just educating her to call us if it happens again. And so not everybody's being brought in more. Some of it is just, really listening to our patients, listening to their concern. And I think patients are really receiving it really well and are really happy about it. So,
what do you say to the OBs that say, I tell my patients to call me if they're concerned, or I already tell them that I'm concerned about this without actually saying the word stillbirth, or actually, what do you?
I talk a lot about the
that?
retrospective data, and I remember it was very profound. We were kind of talking about the data at the conference that a large percentage of our moms either think stillbirth didn't happen until it happened to them, and that this was something that was long gone. So they may not truly connect why we ask them about their baby moving. They may not. They may simply not connect that. And the other thing is that I think was very profound is that there are many women who said they had multiple NSTs